Um, that thing has happened where my mind has just gone blank. Mike, hello.
Hi.
I had that thing. I was like, what's his name? I know his name. I've known the guy for years. Where's his name gone? Mike Delaney. It's lovely to have you with us. I'll introduce Mike properly in just 1 second. I might edit this out in the edited version, but it's live, so there's not much I can do. But anyway, because it is live and stuff like this happens, it'd be great if you joined us. You can give me a call on my mobile, 07506 319 745, calling from outside the UK, +44. And drop off the first 0. You can get through on WhatsApp, and we're streaming live in various places on YouTube, on my YouTube channel, on my Facebook page, and on my Twitter. So if you're on any one of those and you want to drop in some comments for me or Mike, not for me, I'm boring, but for Mike, then we'll sort of get them through to him. My team message them through to me, and then you can be part of the conversation. Enough of that. Back to Mike. Hello, how you doing? Good to see you.
Good to see you too. Thanks for inviting me on.
Oh no, it's great. I mean, it's odd. We've met at conferences, but it's been ages since I've seen you.
Yeah.
Do you remember that? Do you remember that world we used to live in, where you could go to conferences and things like that?
Yeah. Actually see real people, yeah.
It's like some sort of Tolkien story, isn't it? You know, set in fantasy land. So,
I've done a few on Zoom the past.
Have you?
That have been really good. Yeah, I did Bessel van der Kolk. I did one where he was
wow.
And Peter Levine was presenting, so it was really interesting.
Yeah, I've seen both of them as well. It was wonderful work.
Yeah,
we'll come to that. I mean, it's sort of interesting talking about some of these great pioneers in the work of trauma. Trauma is going to feature a lot in the conversation this evening. We're not going to traumatize you folks. We're going to talk about trauma therapy. Hopefully, we're not going to traumatize you. That's not the aim. It's great to have you here. I know that, because you're out this seems really unfair. You're out in the Caribbean, having a great time, and then you got the bloody virus, which must have been really annoying.
It was not what I expected. I went out there. I went to Barbados for my 60th birthday, to celebrate with friends out there, and fourth day in, I think I started to feel ill, and I thought it was food poisoning. It wasn't a normal headache or cold or symptoms. So I went to the doctor, and my blood oxygen was 54. So
you're kidding?
No,
you were still alive.
I was still alive. The next thing, I was getting huckled into an army base in quarantine.
Yes, quite.
Yeah, so it was quite an experience.
That's extraordinary.
On the subject of trauma, do you know what I mean? It was to suddenly be put in a place you weren't allowed out. I was with strangers. People died in the same building as me. Do you know what I mean? It was a tough few weeks.
Yeah.
And then the airports were closed, so I was stuck in Barbados, which people laugh and go, being stuck in the beautiful Paradise Island, but it was closed. So everything was shut. Nobody was anywhere to meet. So
yeah, I know. And it was really, really tough. I remember you posting on Facebook about it. And, I thought it was very good that you were sharing your experience, actually, because it was still relatively early in the pandemic and there wasn't much personal experience being shared. And I thought it was very helpful. It was also, I think you experienced a lot of kindness from people out there as well.
Absolutely. I've known that island since the 80s. I started going there way back, and I've got lots of friends there that I know and people that have grown up there. But the kindness during that week, those few weeks when I came out, was unbelievable. Yeah. I was so surprised that even there was no shopping because they introduced a curfew, so you couldn't go out unless your day was set with the alphabet. So I was Tuesday and Saturday. So I came out on a Sunday and I phoned this shop and said, can you deliver some stuff? And she delivered a ton of stuff and wouldn't take any money for it. And I think that was a fine. I broke down at that point. I'd done the 4 weeks and held myself together, and that just finished me. I sat on the step and went, I don't know, I can't do this. It was just so lovely.
I really remember, I was very touched by that, because I remember I broke down as well. And I thought, this is extraordinary, because there's that thing, isn't it? Like, you have all these zombie apocalypse films which describe how we're going to fall apart and start eating each other and killing each other and all that sort of stuff. And it just didn't happen. What happened was what happened to you, that people reached deep into their kindness and started sharing that and started banding together.
As you say, it was early, so at that point, nobody knew how infectious it was.
Yeah.
Even the nurses I was working with were in full PPE, and I said, I really admire you guys because you don't know what's going to happen. You don't know if you're going to take it home to your family or whatever. It was a really dangerous, frightening time in the early days. It was scary. It was scary.
And people did band together and still have, I think. And I'm absolutely blown away by the effort that everybody's put into sort of managing this pandemic. It's been extraordinary, and it continues to be extraordinary. I mean, I don't want to be Pollyanna about it, but because it is horrible. It's really tough. I'm feeling it without a doubt. But we are witnessing something that's never happened in human history, which is we are stopping a pandemic voluntarily. And with medical interventions, with sociological and social interventions. It's never happened before. And for all the criticisms, and they're all valid, I know that, about people acting too slowly or too much, or too, okay, that's fine. But still, it's absolutely remarkable what we've done.
It is, and I think it's going to be so far-reaching we don't even know at this point. There's so many changes going to happen. I get a bit worried when I see people saying, I can't wait to get back to normal, because I don't see it ever going back to how it was. But I think we just need to find a new way of doing things.
What are we going back to? We're not. We're going on. And I think there are certain changes. I just want to, let's talk about that in just 1 second, because I think that's really interesting thinking about that. But I just also want to stay with you because I want to, share some compassion with you, because I know you're still struggling from the COVID stuff, and this is quite some time later. Are you okay to talk about that?
Yeah, it's about 9 months. It's about 9 months later now, and there was a period where it felt, I think there's a relief when you don't die. There's a kind of a relief and a gratitude that, thank God I'm okay. So I almost ignored some of my symptoms that were continuing because I wanted to be well. So there was a bit of denial kicked in so as I could carry on in my life again. And then it got to a point where it was stopping me. I was getting breathless, and I don't normally get breathless. I was some days waking up and I was so tired, I was just having to cancel the day and go back to bed. It was coming in little spats like that. Every few weeks I would have a wipeout. And I got to the point where I said, I need to deal with this because it's getting worse. And I was getting, what was initially my symptoms was coming back. So my back pain and gastric pain and stuff like that. I was thinking, I need to deal with this. Doctors still don't know. So I went to my doctor and they're like, we're still in the early days, we don't know. So everything's being treated symptomatically, but more or less, I got a chronic fatigue syndrome diagnosis last week. So I've started a course of treatment, not kind of traditional. I think I don't want to start taking painkillers and all that kind of stuff. So I've started a homeopathic, which is working really well, and a lot of vitamin supplements. I think it's a really important conversation to have, because we're going to be living with the after effects, some people very directly, like yourself, for many years to come. But also, I don't know if you've come across this as a clinician, but something I've been noticing more and more is, say, people who didn't have had very mild or no symptoms at all, but they're still having post-COVID stuff, such as, there's people are turning up saying, I've got depression. They look like they've got depression. And then you do a personal history and you find out, well, they actually were infected. They had COVID. And they're not responding to traditional sort of depression interventions such as CBT, because actually what they've got is post-viral issues. And the depression is a symptom of the post-viral stuff. And it has to be treated as a post-viral illness. And the fatigue is the really crucial bit of that post-viral illness. Not so much the psychological presentation, but this fatigue thing that needs to be dealt with because of the way the virus affects the blood-brain barrier. And so, I think it's really important that we look at that, particularly with kids, for example. I'm noticing that young people and kids are sort of getting the COVID, coming through it, no problem, no symptoms or very mild, but then
sometime later develop these symptoms, and then erroneously being diagnosed as depressed. And yes, they have symptoms of depression, but they're not depressed. What's actually going on is this post-viral stuff. So I think it's going to be really important that we continue talking about this now.
Yeah, I agree. And I think you're right. I think I'm seeing a lot of young people, and my daughter as well, we share a house and we do similar work. She gets a lot of referrals from young people. Yeah. And it's anxiety and depression is the main reason for coming. But I believe what you've just said. I think young people, many of them have had it and not realised. Yeah. And even the general population, I've got elderly relatives, I'm sure had it way back and it never got diagnosed. And they're having similar things to me now. So it's everywhere really, and it's often not been recognised.
And I think mental health professionals in particular are going to have to look at their evaluation and assessment tools. Excuse me, as you know, I'm post-COVID, so I'm a bit breathless and a bit sort of coughing myself. But I think in particular, mental health professionals are going to have to look at this and make sure they do good personal histories and maybe make an assumption that this fatigue issue is there. Because, of course, one of the major sort of components of depression work in CBT, for example, is behavioural activation, which actually just doesn't work with fatigue.
No, it doesn't at all.
You have to have a rehabilitation approach with it.
Yeah, even when I went to my doctor, and I went first weeks and weeks ago and said, this is what's happened to me, and my GP said, I think you might be depressed. And I went, I'm not depressed. Yeah. I'm telling you, I'm not depressed. I'm not getting anything in my head that's caused. This is a physical thing. My body is exhausted.
That's exactly right. Sleep. It's understanding that it's a physical thing and it's a physical trauma, and it needs to be understood in that way. Yeah. And you need physiotherapy as part of it, as part of the course. So, like in my recovery at the moment, I read a very good article in the BMJ which looked at this physical recovery period, and it seems to be working for me. So 7-day blocks of certain types of exercise, and you gradually improve it. All of that sort of stuff, you know, which is working. And I'm very lucky it was very mild. It's not your story. I mean, it was touch and go for you at times.
It was scary. Yeah.
But it's sort of interesting that also while I had this breathlessness and this fatigue, and in slightly more severe than today, for example, I was very frightened. I have to say that there was a big fear reaction. And I have, like, my watch does my blood oxygen level.
Of course, right.
So, because I bought it right at the beginning of the pandemic for that reason. Yeah. There's a sort of virus going around that affects your breathing. The blood oxygen levels are the crucial thing. Yeah. And even though this was telling me, you're okay, you're in the 90s, it's fine, I was still, the stories that are out there tell you this is a death sentence, this is and I'm like going, no, stay grounded, stay cool.
It's true though, it's true. Anxiety can spiral up and then your symptoms become overwhelming.
Absolutely. So I actually didn't tell very many people when I was in the more symptomatic phase. I've only I've only told people today really when I'm well into recovery, because I just can't deal with all their anxiety. The truth, I was like, my brother phoned me up earlier going, why didn't you tell me? And I'm like, because I didn't want to deal with your feelings about it.
I know, it's the way it happened to me. I was in a prison barrack, so it was really scary because I was stuck with initially 10 people, maybe I didn't know, one toilet in a barracks room, and then you saw the people starting to get ill. I was feeling ill, but then I saw people getting ventilated, and I saw one young fit man drop to the floor and couldn't breathe. And I've never, all my years as a nurse, I went, oh my God, he's going to die, because he just couldn't get breath in. And he got well, actually. They took him away in an ambulance. He was ventilated, and they brought him back a few days later. Yeah. And he said it was like my windpipe became a drinking straw, and that was all the air I could get in. That's why he described it. And it was frightening to witness as well. It was frightening.
Yeah, very much so. Well, I'm glad you're back with us. Dave, it's really good to have you here, back in the UK, up in Bonnie, Scotland at the moment.
Scotland,
just outside of Glasgow. returning to your roots, I think.
Yeah.
That's sort of the area that you grew up in, a bit further north, wasn't it, that you grew
A bit
up?
further north, yeah. I was born in Stirling,
Yeah.
and I grew up over in Stirling and went to school over that way. But in 2017, my mother passed, and it's the death of my mother and dealing with that grief was very different for me, and it culminated in me saying, I'm going home. And it was really strange because I never had the urge to ever go home, because I always had too many friends in England and my life was there, and suddenly there was just this decision had to be made, and I just, within 3 months I was home. It was just as quick as that, and it's really been a great decision.
Yeah. Had you trained as a mental health nurse by then?
I did, yeah. I trained when I was 17. I became a nurse, and qualified when I was 21. So I worked in the hospital, the old mental health system, the large hospitals, like 1,200 bed hospitals.
I remember it well. I did a lot of work up in Scotland, as you know, in Edinburgh, working for Lothian Primary Care Trust. Right. And so worked on the Gogarburn enclosure, which was one of those big bins that existed.
The big bins, yeah. Well, I was in Larbert in Royal Scottish National Hospital and Belfast.
Oh, wow.
Yeah, they were big old hospitals.
I mean, the thing that shocked me about Gogarburn was that it had its own crematorium, and I was like, I just couldn't get my head around that concept. It's like, what on earth that people were going to be born here and die here, and somebody thought that was a good idea.
Yeah, I know, awful. I mean, I say awful, but at the minute there's no services at all. So I think, in some ways, I wish we still had something like that where people could go when they needed help, because there's nothing anymore.
Yeah.
You know what I mean? It's awful for people who've struggling, suicidal, and they get told maybe 6 months you'll get an appointment. It's that kind of situation. Yeah. But like you say, the culture back then, we had a farm in the hospital. I trained people, worked on the farm, provided all the food to feed everyone. It was like a self-sufficient community. And in England, I moved down there initially and worked in the hospital system in England. But then I became a CPN. I was in London and I was responsible for the closures and moving people out and getting them more community-based. It was all, I mean, I still remember some of the older women particularly, and they had moral defective stamped on their diagnosis.
What? I know. I tell you what, one of the experiences I had in Gogarburn, I kid you not, was one of the, because technically Gogarburn was a learning disability hospital. I remember doing, I was doing some drama therapy at the time, a session with some of the older ladies. And I just thought, I wonder what would happen if I pretend to fall asleep. And so I did, I pretended to fall asleep. And one of the older ladies, who's obviously a morally defective label, snapped out of her learning disability, went into completely like you and me, and organised the other patients, sorted out their tea and coffee. And as soon as I started to wake up again, she was back into the learning disability performance. I mean, instead of people had told me about this, and I was like, no, that's not true. But actually, it was. I mean, it was extraordinary times.
Do you know, you've just reminded me of a story. When I was a CPN, so I was based in Leytonstone in East London.
Yes.
But we're connected to Claybury Hospital, which is gone now as well. They're all gone. Yeah. But at the time, not just before that, remember the Romania thing happened and all the orphanages were found in Romania.
Yes.
So there was some exchange visiting going on where people from Romania were coming and looking around hospitals. And they walked into a ward in Claybury Hospital and they were speaking Romanian. And a woman who had been there since the 1939 or 1940 stood up and started speaking Romanian. And she had been in London during the Blitz and had got separated from all the people that were with her and couldn't speak English, was in a hysterical state. Obviously, she was in the middle of a bombing. And they put her in Claybury Hospital, and that was her for the rest of her life. And she was, I think she had hypophrenic schizophrenia written on her diagnosis because she didn't speak. And she just sat quietly for 40 odd years. It was shocking. Wow. But I think because it came out, it was in the papers, and she got reunited and got sent back to Romania and everything. But I wonder how many other people were in that situation.
Yeah, absolutely. And in many ways, those hospitals made economic sense in their time because they were these self-sufficient communities. And in the days before industrial laundry and all that sort of stuff, they'd make money out of the local community by washing their clothes, providing fruit and vegetables, as you say, sewing bags for the post, etc., etc. So they were their own little industries.
Lots of them used to make the airline packs for your meals, the kind of cutlery wrapped in napkins and stuff. They sat down
absolutely. And that was your life. I mean, we have advanced, I think, in terms of treatment now.
Definitely. We've just got nowhere for emergencies.
Yeah. I mean, and things have moved on. And in terms of the model of practice, I think it's second to none what we do in the UK. It is difficult because of the postcode lottery and because of resources and coordination. These are the main issues, I think. But actually, the practice itself is extraordinary and is well beating.
Absolutely.
Well beating, I think, without a doubt. But it's under strain. Hopefully, one of the things, and let's talk about this, what you think will happen post-COVID or post-pandemic. And post-pandemic, it's difficult to know really what that means. I mean, I think that, by this time next year, sorry, folks, I know you all want to be out of it, but I think by this time next year, we will be post-pandemic because we will be managing it.
Yeah, I think you're right. Yeah, I think it's going to take that long to get all the vaccination and herd immunity and all the last vestiges of infection kind of under control.
And then the ongoing vaccination program that will need to be around the COVID as it mutates. And we're probably looking at least for the rest of this year, sort of social controls of some sort and the use of masks as a standard and enhanced hygiene, etc. It's also, I think, that we're going to have to look at, because you've probably seen the reports that we virtually wiped out flu, but of course it hasn't gone anywhere. It's just, and so there's a big issue about next year about, if we suddenly drop all these things that have got rid of flu and we don't have the immunity from having caught it this year, so there's some unintended consequences to process, which is why I think, this is going to go on for a while, but this time next year, I mean, I think we'll be on top of all the management strategies and we'll be in that new world, whatever that looks like. So I think that's one of the changes. But what sort of changes are you seeing at the moment that you think are sort of relatively permanent and here to stay?
I'm seeing lots of people actually, I see lots of positive things because it's not all negative. I see lots of families that are actually getting on really well and that have stopped a lot of behaviours because everything's closed. So families that had kind of disjointed and men were at the pub and women were going out with the girls and all that kind of stuff and they didn't really get on. They've been forced to look at the relationship, I think, in many cases. And people are actually back working with their families and I see a lot of positive stuff. The other side of that is I see some families that are never going to be able to survive this because it's too much and there's too much aggression and hostility within the system. So I think mental health services are going to have to deal with a lot of stuff coming out of this as well. Whether it be mental health or whether there's a combination of physical and mental health, to start looking at this, because I think the diagnosis of depression, as you've just spoke about, is going to have a major effect on people's mental health ongoing. So work-wise, hospital, doctors, everything's going to be flooded. I think so. Part of my desire really is to get things like other therapies up and ready and started working already. So things like Equine, where young people can come and actually offload and rebuild some resilience and some confidence in themselves.
So now that you've mentioned Equine, tell me about it. Tell me what this mysterious, strange thing called equine therapy is. Well,
about 18 years ago, I was involved in opening a rehab in Gloucestershire called Steps with Sam Quinlan and Dominic. And we were having these planning meetings, and every meeting Sam would say, I'm on horses, and I would go, Sam, and we'd carry on, just ignore that.
I can just hear Sam saying it now. I know exactly how she went.
And it was all because you had seen 28 Days with Sam.
Yeah, whatever. I don't know. It's just like, who knows how Sam's mind works?
Yeah,
it doesn't matter. It's just like this stuff comes out.
Yeah, it came out, and I kept saying, "What do you mean horses?" I was like, "I don't get it." And then we found this 2 people in Scotland called David and Annie Tidmarsh, who were trained in America and who had worked in Arizona and some of the ranches. So we brought them down, and I still remember standing looking. There was a menage with 3 or 4 loose horses, and they were doing a demonstration. They were our horses. They were Sam's mother-in-law's horses, so they had never met them before. And they had done an exercise, and I was watching, and then they said, we're going to pretend that we're going into conflict, so we're just going to raise our voices slightly, and we want you to see what the horses do. They were wearing little boom microphones. And I was watching, and the 4 horses were looking into the distance in the corner, and all David looked at Annie and went, well, I'm not happy the way you did that, and he slightly changed his tone, and the 4 of them turned around at once and then came towards them, and one of them went right between and pushed the female away to kind of protect her. And I was standing watching this, and I felt a big tear coming to my eye, and I went, oh my God, what's going on here? Why is this making me feel like this? And it was fascinating. And then I started to realise that this was a non-verbal way of engaging people who couldn't talk about what was going on for them, who didn't have the words, or the trauma was closing the frontal part of the brain and they couldn't verbalise. And people coming in for addiction treatment, there's usually always trauma. So it was working with them who were in treatment, I started to see all these amazing things happening. And it's about connection, it's about relationship, it's about people who feel absolutely ashamed of themselves and have got no self-esteem, and a huge animal comes up and breathes into your face. They take that as, that animal likes me, that animal thinks I'm okay. So you get this outpouring of grief and sadness and all the kind of stuff that they've never been able to release. The horse just seems to be able to push a button and it happens. So I got used to seeing that all the time, and I got used to seeing which horses were good at which things. Some horses stepped forward and dealt with grief. Some horses had their own trauma from humans and identified with other trauma in human beings. So it became fascinating for me to see that. And at that time, we had about 14 horses at that time, all with a different story. So it got to a point where when I brought a new client into a field, I kind of got an idea of what was wrong with the client by the horse that walked forward. So it became that kind of attuned. So that's 18 years, and I've still not lost any of my enthusiasm for it, because I see every day that I do it, I see this stuff happening. Yeah. With different horses. I work with horses I've never met. The same things happen. It's just about human connection and an animal connection. There's a limbic kind of brain connection happens from way before we had speech and language. We still fire, I believe, on that prehistoric brain. Yeah. And so do horses. If you look at cave paintings, horses are some of the earliest things that were painted. Yeah. So we've been running with horses for many years, and sometimes we were getting chased by the larger animals as well. Yeah. Because horses are attuned to danger. They're prey animals. Animals kill them, so they're always they're hardwired for safety. So they kind of pick up every kind of change in emotion because it might affect them. So it's fascinating to work with, and it's fascinating.
Absolutely, absolutely. It's interesting that there's been, quite a lot of research and looking into how animals manage trauma, because it's interesting that animals seem to manage it better than we do.
Absolutely. Peter Levine, I just love Peter Levine. His work is amazing. Yeah. And that's kind of drove the trauma release type of exercises, the somatic experience and stuff. His description of impala getting chased by the big cat and separating it from the herd, and it chases, and then the big cat gets tired and the impala finds a safe place, lies on the ground and shakes for a few minutes, and then stands up and eats its grass, and it's back to normal. Yeah. So that kind of releasing it from the body, we live up here too much now, and everything's done in the head, and you can't deal with trauma in your head because it's a physical, it's all through your body, it's in all your muscles. it needs to be released differently.
Yeah, I'm getting the impression as you're talking, you have a more intimate connection and a clinician to these whole issues around trauma. I'm guessing that you've had experience of trauma yourself.
I've had a fair bit of trauma through my life. I mean, in my childhood, where I grew up was pretty rough. There was 10 of us in a 3-bedroom flat. It was a strong Catholic area, so it was a tough upbringing. It was a tough upbringing. So there's stuff from there. There was some abuse from a stranger at a certain age that I had to deal with. Stuff that you I remember, this will describe it, I remember being in rehab, and the first thing you did in rehab was present your life story to your group. And I sat in rehab reading my life story, and I remember stopping because the other 10 people in my group were all crying. And I went, why are you all crying? And they went, that's really sad what you're saying. But I was disconnected completely from it because that was the coping mechanism. That's what happened to everybody. That's what I believed. So I didn't see it as trauma. And then you can't survive for 20 years in addiction and not have trauma as well. So addiction's traumatic in various ways. So yeah, I understand how I could think I've dealt with something, but physically I haven't. You know, sometimes I get triggered and it's a physical reaction.
Yeah, I think that's the reality. You started to talk about different areas of the brain, and we can go into that in a minute. Just before we do that, though, if this is okay to break off a little bit, I've just got a message from my team saying we've got a question from Kieran, and I wonder if I could read the question out to you, and then see if you have any thoughts or answers, and we can have a chat about it. Is that okay, Mike? Yeah. Okay, so Kieran says, I've had COVID and noticed a change in my concentration, anxiety and fatigue post the COVID. I'm a psychotherapist and constantly noting and tracking my own reaction to COVID issues brought to therapy as my own experience and emotional reaction to my experiences brought into the room. Any advice on managing this transference? Also, do you have any other thoughts around things you think therapists need to be aware of as a presentation in therapy in this context?
Right.
Quite a long question, but I think it's clear what he's asking.
Yeah, I think for you personally as well, I think part of this fogginess of the brain that you feel as the therapist as well, I struggled with that to start with.
Right.
Because I struggled to properly hear what was being said to me. It can affect you in such profound ways that you're not used to. One of the things that helped me with that, believe it or not, was CBD oil. I was recommended using CBD oil for the foggy brain, and that really works. I think talking about COVID generally, making it part of the conversation, not just about I've had it, just generally, how are you coping? Do you know anyone? Anybody in your family got it? How do you feel? So kind of getting an impression of how they feel about it and how they're managing it as well.
Yeah. And I think, you know, from the perspective of the therapist, also thinking about what was your experience of having it and what is your experience right now? And are you talking about that experience with your supervisor and with other colleagues so that you're processing and understanding what your reactions are? Because I think what we have to accept is our reactions will have changed.
Yeah, no, definitely. That's
because, you know, because COVID isn't just an illness. It's a pandemic that has restructured society.
Everything.
And I think as individuals, we can't imagine that hasn't affected us.
Yeah.
And so it's about
an understanding supervisor, I would say, is a prerequisite. Sometimes I take that for granted because I've got it, and I don't always think about it. But I've phoned up my supervisor and I've cried, and I don't know in that moment why I'm crying, but I just know that stuff's affecting me and making me kind of weep and release. But I just let it go. One of the advantages I think I had, because when I came out of quarantine and then I had a period before the airports opened, I was on my own. And so I was able to allow my body to do what it needed to do. So I had some really tearful days, and I had some no speaking to anybody days, and I just allowed, that's a word, I just allowed my body to do what it needed to do in that moment, and released whatever it was that needed to be released. And I think that really helped me to be able to stand back a bit and separate and still be able to function in a one-to-one situation.
Yeah.
Because that's difficult.
Yeah, Kieran, thanks very much for the question. I hope that is helpful and thoughtful for you. But I'm sort of, the world has changed, and this is it. We have to adjust to this world that we're in now. But a really good question, I think, one for practitioners to think about. Because the more we think about this stuff and process it, the more we're available for our patients, really, in that sense.
Yeah, absolutely.
So honest questioning about how crap this is sort of really good. It's really good getting to it. So thanks very much, Kieran, for that question. If you've got any more, send them through to us. And if anybody else has got questions, it'd be great. Or just thoughts and comments and experiences. We'd love to hear from you. Let's come back to trauma. And I sort of think that question was a bit about trauma as well, because I think what we can't escape is that to some extent, this has been a traumatic experience, the whole thing. If you go with the definition of trauma that is environmental, which is high levels of stress associated some way with death, you have the precondition there for PTSD to develop in somebody. So that's how you diagnose it, and then you look at the individual responses. But I think there's some sort of cultural trauma that's happening, and we need to think about it like a war, like the Second World War, existed at this level of rupture at the cultural level, not just the individual. So I think that processing is going to go on for a while. But thinking about what you were talking about trauma, how it impacts upon the brain, do you mind just talking a bit more about that? Because you began to talk about, the frontal lobes, the limbic system, etc., etc. So just take us through that bit, if you don't mind.
Well, I think only because we now understand the brain much better than we ever did. I mean, half of the stuff I was taught as a nurse, as a student nurse now, is rubbish. I look back and think none of that was true, but it was what was believed at that point. So I think we understand now which parts of the brain light up when certain things happen. Addiction, the kind of pleasure centres, the neural pathways that keep us doing the same things. But I think we only understand now that trauma, therapists say, tell me what happened. Tell me about your childhood. People might try to tell you, but in that moment, the whole biology changes. The frontal lobe closes down. The kind of fight or flight starts. The whole polyvagal system kicks in. So they're just unable to do that at that point. It's a silly thing to do, to ask them to tell you about the trauma. Whereas when I work with horses, I've had people that have came to me with complex PTSD, soldiers, SAS soldiers, really, really, I thought they were going to kill me at some points within the rehab building, because if someone banged a door, they were on high alert and they were going to kill someone. But I saw one session at Equine on several occasions remove everything. And I saw there's a kind of, the shoulders, for the back, you see the shoulders droop, and you see this big hulking man suddenly start to cry, and then the crying becomes sobbing, and this uncontrollable release that goes on for 20, 30 minutes. And at the end of that, I say, how is that? And they just go, it's gone. And that's the kind of response, it's gone. And I've got people that 10 years later haven't had a flashback. And this is, one person in particular was 12 years in military hospitals being treated for alcoholism and PTSD. Although they don't treat PTSD because they don't believe it's real. So they don't say that. But one session at Equine, we did some follow-up sessions, but the breakthrough happened in session one and everything changed. And that happens regularly, that level of transformation within someone. And I still don't know what the trauma is. They've left and they've gone back to their life, and I go, nice to meet you, keep in touch.
I think that's really important, Mike, because we don't really need to know what it is.
We don't need to know. We don't need to.
That's right. I remember Bessel van der Kolk, when I saw him doing some training, it was really interesting because he showed a bit of film of a British soldier returning to civil life. It was set in modern times, and the soldier went to the supermarket. I forget which one it was, Sainsbury's or something. and a child was being irritating with their mum, which then triggered him into a flashback, and then he lost the plot.
Right.
And wasn't violent, but was aggressive. And then he came out of the flashback, and he was ashamed and embarrassed, and he left the shop. He wasn't able to do the shopping, and he felt bad about himself. And what Bessel said was, the point of the therapy with that guy is so he can go shopping. It's not so that you can make some clever points or prove how wonderful you are, because what's important is he can go shopping. And I think that's exactly what you just described, is that if it works and somebody can then get on with their life, that's great. You don't need to know any more than that, do you?
No. And I think human beings are programmed to be inquisitive. And I think when I've been doing equine a long time now, and one of the hardest things to learn is to shut up. Stop asking. Do you know what I mean? Allow the horse to do what it does. Stand back as long as you can. So sometimes people say to me, when are you going to do something? I go, I don't do it, the horse does it. Yeah. And then at the very end of that process, whatever the human wants to talk to me about. So the beauty of it also is that you never give an answer. In a room-based situation, a therapist can have an idea what they think's going on, and they can start to direct the client down a certain street. You can't do that with equine, because I ask them what happened during that session, and they tell me, this is what happened. The horse did this, and I felt this, and I changed this, and the horse did this. So everything comes from the client, every single answer, every solution, even reflective work. So I do a lot of reflective work. It's fantastic for trauma. So just getting somebody into their body scanning, body awareness, and then I say, just go and be with that horse and leave them. And they stand with this horse, and they come back and they tell me, the horse told me this, I got a memory of this happened, that happened. And it's all stuff that a lot of people go, that's a load of rubbish. But for that client, that works. And what they give me as their explanation, I absolutely believe. And that's what the solution, they find their own solutions. And I don't see that happening so much with lots of other things.
It's interesting, just coming back to this point about asking people to endlessly talk about or remember the experience, because in many ways, the point of the work is to help people forget it. It's their inability to forget the experience, not in a cognitive sense, but in a physiological, interpersonal sense, that is really messing them up. And actually being able to let it go and forget it and not be coming back to that is exactly what you want. I'm not dissing here more cognitive approaches such as EMDR. I'm definitely not, because I've seen it work extraordinarily for people. And I think that what we need is more, not less.
Yeah, absolutely.
We need more interventions rather than less interventions. And we need to sort of be working with it. And I just remember I did work when I was in social services, a manager in social services. I was running refugee services, and so I worked a lot with people who've been tortured and things like that. And we often didn't know how to help somebody, and so we would have to go to them and say, I don't really know, but shall we give this a go, and then you tell me whether it's helpful or not. And there was often cases people came back because we'd said, why don't you go for a walk in that wood? And they'd come back and said, oh, it was bluebell time, and that's really helped, and I feel so much better. And we didn't need to analyse it and go.
Exactly.
It was just we were finding stuff that worked.
Yes, and I think Peter Levine talks about having a relational home, and the horse can be a relational home. PTSD happens generally when people don't have a relational home.
Yes.
So if you can substitute that with the horse, it becomes that connection. It becomes that safe place. And that's what I found with young people. When I did a project with 43 young people over a year with horses, and it was amazing. And it was young people nobody wanted. It was sexually harmful young people who were kind of brushed aside, and they were the most amazing kids, and the connection they formed with horses stunned me. And stuff that they disclosed to the horse, knowing I was right at their side and I was hearing every word of it, but they didn't trust humans anymore. So horses also become a bridge back to trust in humans and trust in professionals, because lots of people have been traumatised by professionals as well.
Yeah, without doubt. I mean,
Yeah.
without doubt. I mean, I worked with torture victims. I'm telling you, there were lots of highly trained professionals that were torturers, and it was sort of like revolting stuff.
Yeah.
Just thinking about that a bit more broadly, because there is something, I think, and I'm wondering what you think, there's something very helpful to people who may feel broken in their capacity to relate healthily to themselves and others. Not just with horses, because not everybody has access to them, but I think animals in general.
Absolutely. Animals. I mean, I don't think there's an animal, cats, dogs, anything that's about the house that can sit. They're very sensitive. They're very attuned.
Yeah.
I know a lot of therapists now who leave the door ajar, and at certain points when their client's upset, a cat or a dog comes in and sits up and gives reassurance to the client. So that kind of goes without saying. Animals are way ahead of us as far as picking up energy and how they can maybe help in that situation. But even horses, it doesn't need to be therapeutic. I say to people, be a volunteer at a stable.
Yes.
Go and do something where you're around them. You're learning to trust that big, huge being. I worked with people from London Underground years ago who had trauma. Some of them had jumpers in front of the trains, and after 7/7 there was a lot of trauma, and so a lot of addictive behaviours started. And some of them went back to London, and one man in particular bought a horse, and he just had it in a little stable yard in North London somewhere, and he finished work every day and looked after the horse. But that gave him that connection, and that I also remember working with a girl with anorexia who was probably one of the closest to death eating disorder girls I've worked with. And I saw her getting close to a big horse, and she started crying, and I just said, "What's happening?" And she said, "That's the first living breath I've felt on my face for years." So she had never allowed anybody close enough to feel breath. So that moment, it was like my whole body went, "Oh my God, I hadn't thought about that." The closeness of another living being breathing.
And of course, for a lot of us at this point, that physical closeness is missing. So I live alone, and I'm really missing hugs.
Yeah, absolutely.
Really, really, very much.
Yeah.
And
I think that's very much, I think that's driving a lot of the anxiety and stuff, as well as the kind of human beings. I think touch is as important as food, and needs to be constant, even for reassurance, for friendship. Touching people in the street, it's just gone. And it's really strange, especially when you meet someone who's, I've got an aunt who's in her 80s and old, and I just want to cuddle her to death. But we can't, do you know what I mean? We might kill her. So it's really strange for human beings to be in that position.
I think so. I mean, there may be some cultural shifts that happen there that are relatively permanent, in that, there are cultures such as Japanese culture, for example, which have much less physical contact. They still have physical contact, but it's much more structured. It's certainly not social hugging and all of that sort of stuff. And we may see shifts along those lines, but it'd be nice to get to a point where it doesn't feel like your breath is a killer to somebody else. That would be a relief.
It's a strange feeling.
It's really weird at the moment. It's really weird. And if anybody's struggling with it, you should be struggling with it, because it's not easy, this stuff.
No, it's not easy at all.
Coming back to trauma and addiction, because you mentioned earlier on that you see a link between the two, and also before the show started, we were talking about the differences between addiction treatment way back when, and both of us are dinosaurs, so we remember way back when. Certainly I am. I won't talk for you, but I'm sort of old enough to have known pterodactyls.
Yeah, me too.
And the changes now, particularly with the trauma-informed approaches. So, what was it like, addiction treatment, and what is it like now, and what's the place of trauma within that?
I think it used to be what was called the Minnesota model. So it was a 12-step based treatment that was brought over from America in the 70s, and the whole thing was brought over lock, stock and barrel. So they never made any cultural changes. America was very much had a Bible Belt, and God was part of everything, and so it worked wonderfully out there. And they also kind of, the American culture will be obedient to authority and will do what they're told. So there was a kind of shaming approach. You were punished for certain things. And I found the whole experience, it saved me. Don't get me wrong. I was in a terrible mess, and that got me off everything that I was taking and pulled me out of addiction. But I realised at the time, because I was a nurse when I went in there, that some of it could be done better. And some of the shaming and some of the consequences, it was always consequences, powerlessness and consequences. And they used to have a whiteboard up, and it was written what your powerlessness and consequences were for that week. So everybody saw your stuff. If visitors came in, your name was up there. And it was kind of punishing. Trauma was never mentioned. I heard girls, I remember a sex worker coming in from Birmingham when I was there, heroin addict, covered in cigarette burns from a pimp, terrible mess. And she wanted to talk about her trauma. She wanted to talk about what had been done to her in order for her to start getting well. And it wasn't allowed. It wasn't allowed. You deal with your step one, you stop drinking, you stop taking drugs, and you can deal with that when you leave. You can go to your therapist after. And even back then, 1996, I was sitting going, no, I don't see how that's going to work. So I've always felt that trauma needed to be addressed. Maybe not, it's not going to be fixed because it's an ongoing, longer term thing, but it needs to be opened and looked at and something cleaned out, and then maybe a plan put in place so that the person knows, right, someone knows about this now, someone knows how I feel, and someone's trying to help me. Yeah. But I think the kind of closing down, I ran a place, one of my first jobs was a large place called Barley Wood, which was a prison forensic. A lot of people from London came and went straight into treatment. And I remember overhearing a counsellor shouting at a girl because she mentioned sexual abuse. And I heard him shouting, "You ain't doing that here. You do that when you leave here." Do you know what I mean? And I had to actually go into the room and say, "What are you doing?" And kind of consult the girl and get rid of him kind of thing. And it was awful, but that was the way things were done then. It wasn't, you wanted to talk about it. And I think a lot of it was because at that time, counsellors were poorly trained. Some of them weren't trained. Some of them were just sober. And they had got sober in that rehab, and they became a counsellor in that rehab. So all they did was repeat what they saw happening to other people and what happened to them. Whereas because I was already a mental health professional when I went into rehab, I had a different outlook. So I kind of thought, I like that, but I don't like that. And then over the years, I've tried to be more trauma informed, and it's been a difficult fight because a lot of professionals don't like it. They don't like the fact that something's going to open up that you might not be able to handle in one session.
I mean, I get the fear stuff. I think there's also some stuff like in the Minnesota model, the sort of 12-step model, which is very much about you have to take responsibility no matter what.
Yeah.
And there's everything, if you start to talk about things that have happened to me, it then gets framed as those are excuses.
Yeah.
And they're not. They are things that have happened to me, and they need to be sort of understood, and they are probably our drivers to using.
Yeah.
And that's the truth and the reality of it. And I think there's this. It's difficult. I mean, it's a difficult conversation because, I mean, to be honest, I pissed off the recovery industry already, so I don't really care.
I remember that. Yeah, I remember it.
I don't really care about pissing them off again, so it doesn't really matter. But this whole identity level stuff that goes on around, you have to be this certain thing, and you have to fit into it. I mean, I was literally talking to a new patient about it today who's had intervention after intervention saying, right, stop doing that, accept the fact that you're an addict. And he's quite rightly going, why? What the fuck? Do you know what I mean? It's like, why?
It's about that, being able to actually. Very often now I say to my client, what do you want? What can I give you? How can I support you to get what you want? Rather than, you need to do this. If you don't do this, you'll relapse. That kind of shouting at people and telling them what they need because it worked for me isn't a way forward. And I think the definition of recovery as well needs to shift. This kind of, if if you come in and you're on heroin and crack and alcohol, and then you leave and you have a drink, that's your relapse. I'm like, no. I mean, if you came in and you couldn't manage your life, you couldn't hold down a job, you had no relationship with your family, if you come back to me a year later and say, I'm having a drink and it's okay, sometimes I get a bit drunk, and I go, well done. You know what I mean? If that's,
I totally agree. And we sort of bring up that old conversation about medically assisted treatment, for example, which is, I mean, I find it unbearable, this conversation, that anybody could question the value of doing that.
Yeah.
You know, if somebody comes in on some serious street drugs and you give them some medication to get them stabilized and save their life, how on earth could you have an argument saying that that's not recovery? I mean, it's just an absolute joke. It's an absolute joke, to be honest.
About a year ago, I went to a conference in Edinburgh, and there was a guy called Professor Carl Hart from New York who was speaking at it. And he stood on the platform and said, I use heroin 2 or 3 nights a week. I enjoy it. I love it. It's never affected my job. Look at me, I'm a professor. I did this on heroin. And he said, why should a small proportion of people with addictions decide whether or not I can use heroin? And actually, it was like, I went, oh my God, I've never
that would have been quite like, remember that Maxell tape advert?
Yeah, it was completely, because I had been brainwashed in this Minnesota abstinence stuff. And I spoke to him in the break and went, you've actually changed my whole outlook just by that speech about what you do and what you enjoy and how many people enjoy it safely.
There's just, I mean, I think there has been, like you say, the sort of bringing that model over to the UK and to Europe has you know, I mean, it's helped huge numbers of people, including myself. I'm sort of have no problem with that. But it's also huge numbers of people it hasn't helped. I mean, it's like 12% of people with substance abuse problems that works for. And for that 12%, great, fantastic. It's not get rid of, but what can we add in so that we increase that 12% to closer to 100%?
I think it also feeds into Scotland's got the highest drug death rate in Europe. So it feeds into, let's have consumption rooms, let's legalise a certain amount of usage and do it safely within a controlled environment where we know people aren't going to die, and keep them alive long enough they can then engage with treatment when they feel like it, when they're at that point.
That's right. And Scotland's brilliant at sort of thinking about those things. And I think there's a real hope that Scotland will do that, because the death rate is awful at the moment. And mostly the death rate is awful because there's a preponderance of the use of chemicals, and they kill a lot quicker than alcohol. Although we should say, I mean, a report came out today showing that deaths by alcohol during the pandemic, certainly during the first lockdown, we're probably going to be replicated in the second lockdown, have doubled. And unsurprising, because the figures around alcohol usage were absolutely frightening. That you know, the amount of alcohol people were buying from the supermarkets and stuff like that was just shocking.
What's really surprised me is the amount of people that have came forward for the first time for help, and they're in their 50s and 60s, and they've been businessmen and they've had successful companies, but because of COVID, they've been furloughed, everything's shut, and they've not had work to distract them from drink. And so they're stuck at home with nothing to do, and they've started drinking spirits. They're drinking gin when they only ever drunk beer. And I've seen people coming in and terrible messes very quickly. It's happened very quickly.
We are coming towards the end of our time, and it always passes quickly in this show because I have fascinating people on like you. I want to make sure before we finish, because you're also working in a rehab as well as the equine therapy, that we just talk about that, because it's a very interesting place. So what's it called, and tell me about how it works?
It's called Delamere, and it's in Cheshire. About 3 years ago, the founder, Martin Preston, contacted me and asked if I'd be interested in helping him to create a new model of treatment. So nothing that was ever done before. Why can't we start something new? So that's what we've done. The model's called Stop, Start, Grow, and it's a 3-part treatment experience. And it's about celebrating your decision to come in to treatment. It's about celebrating your strength for making that decision, the phases are defined so that there isn't too much pressure. We go at the client's rate, we do what they want to do. There's lots of choices, and it's a very tailored and individualized program. So there isn't 10 people sitting in a group getting the same stuff told to them. There's people dealing with different trauma. There's people getting equine. There's people doing breath work. There's all kinds of things all happening at the same time. And it's been amazingly successful. It's almost a year now. It's been open right through the pandemic. It's been very busy. That's when I've seen so many people coming in with alcohol problems who would normally be functioning well in work in the boardroom. But it's been hugely successful, and the first cohorts that have came through, the reviews and everything are very positive. So wonderful. I'm hopeful that it'll be able to be replicated at some point.
And so that people understand, like the fairly standard model, this is in the private sector, we're not talking about, in the public sector, the model is drug and alcohol teams, which are very, very successful, and they're community-based and are fantastically successful where they exist and where they have the funding and resources. But in terms of inpatient rehab models in the private sector in the UK, is very much like the models in the US, for which there is lots of evidence they don't work. And the model, it often is that when the patient comes in initially, the idea is going to be you're going to break their ego, break their resistances, so that you can reprogram them.
That's how they used to describe it. They smash it to pieces to rebuild you. That was the phrase.
Absolutely. I mean, and it is literally, it's effective, but it is literally brainwashing. That's what it is. And it's brainwashing that saves people's lives. I'm not questioning that, but that's what it is. And so it's really important for people to understand that. Not because I'm dissing it. I think, whatever, it's a voluntary thing. These are not Section 3 mental health referrals. Rehabs are voluntary. People can go and leave if they want. But this is really interesting what you're proposing, because I think this is starting to talk about what the future might look like, to be honest.
I really believe so. I believe so. And I think that people aren't used, because some people have done other rehab, so they come in and they're expecting to be shoved into group. They're expecting a group in the morning, a group in the afternoon, and we go, no, stay in your room, have a sleep. You don't need to worry. When you're feeling stronger, we'll tell you about how it's going to be. So everything's done really compassionately and really caringly. We did a kind of 3-week training block before any clients came in. We all worked. They're called guests, by the way. We call them guests. So we even introduced clean language, and there's certain words that are banned because they've got an agenda behind them. And we're not allowed to use them, and nobody's allowed. The guests aren't allowed to use them either. So we kind of teach them to be more compassionate themselves, self-compassion for each other. So it's a very different, gentle, loving kind of model. It's really nice to sit in among it and feel it. I don't have any kind of, that's not right. It feels lovely. And every client comes back and says, oh my God, this has been amazing, which is great.
And I guess there's a website for it that people can go and check it out if they want to.
Delamere.com.
Delamere.com. We'll make sure that goes out, Mike. We are at the end of the time, unfortunately. It's been lovely to have you on. I'm really, sort of on a personal level, I'm really pleased I've caught up with you, because I was following your story when you got ill, and I was really concerned for you, and I knew that you had the post-COVID stuff, and so this is very important to me to sort of have you on here as a colleague who, has recently been through some really tough times, and we want to show you some love and compassion.
Thank you, I appreciate that, and thank you for asking me. It's been lovely. I've been wanting to connect with you for a while as well, so it's been a nice opportunity.
One day we'll be able to hug each other and not.
One of these days.
All right. Anyway, we've got to finish there for now. Brilliant to have you on, Mike. What a great show this evening. I hope people have enjoyed it and found it informative and useful and helpful. And I shall see you all again next week. And I have absolutely no idea who it is that will be the guest, because I never have any idea whatsoever who next week's guest is going to be. But there you go. Bye-bye for now, folks.